Hello, ladies and gentlemen. My name is Abdul Kadri. I'm an international medical graduate, so I have decided to record a series of lectures for the students that are in need of understanding some concepts for medical school or for their board exams, for example, USMLE and the Canadian board exams. So please subscribe to my channel, and I'll be trying to my best to post some new videos and leave any suggestions if you feel like, or any videos that you want me to record for you guys in the meanwhile, and I will do my best to make sure that I can get you guys the best knowledge from the best sources around possible. Thank you very much. So let's start our first lecture. Today our first lecture is coronary artery disease and stable angina. So basically, before we start, what we're going to do is we're going to have to go ahead and describe a couple of definitions, or define some things. First of all, coronary artery disease is also known as atherosclerotic disease or ischemic heart disease. So let's define coronary disease. Coronary disease is basically coronary arteries it basically refers to the atherosclerotic narrowing of the epicardial coronary arteries. It may manifest as angina pectoris or manifest insidiously as an acute coronary syndrome. So basically what it means is, this is basically the narrowing of, it's an atherosclerotic narrowing of the coronary arteries. Especially, you guys know that which arteries? The epicardial arteries, okay? That's it. And what is a stable angina? And as we said, this can present as an acute coronary syndrome, or it can present as a stable angina or angina pectoris. All right, stable angina is basically a chest discomfort due to myocardial ischemia that occurs predictably at a certain level of exertion or emotional stress. So if you have, for example, excess stress or strenuous exercise, stress or exercise, and it brings on pain, it's referred the chest pain that's of specific quality, then it's referred to as stable angina, but it's relieved upon rest, so that's why it's referred to as stable angina. Acute coronary syndrome itself consists of three specific conditions. That's called ST elevation myocardial infarction, non-ST elevation myocardial infarction, and unstable angina. So we'll talk about this in the next video, but just for the time being, we're going to talk about stable angina mostly in this patient. Ladies and gentlemen, you must be very careful when you're looking at some patients that might present with a non-specific symptoms. For example, just nausea and vomiting, fatigue, and that's all the signs and symptoms are present. And these patients are usually the elderly, the diabetic patients, and a woman population. These population you must be very cautious about. I'm just going to go ahead and put a star beside this, because you don't know, you might want to do some EKG changes or check for some cardiac markers, and all of a sudden you have this patient and you're very tired and you don't realize it, that they can have possibly a coronary syndrome or acute coronary disease out there presenting with that. All right, ladies and gentlemen, so we're moving on. Let's talk a little bit about epidemiology of coronary artery disease. Epidemiology, so they say about it's the leading cause of death for adults in the United States, in both in the USA and the worldwide. That's amazing, right? Wow, what a big disease. So we're talking about, so 80% of this can be actually prevented with lifestyle modification. Wow, this is amazing, guys. So be active and try to avoid things like, for example, smoking and too much alcohol, and, for example, inactivity. All these are the causes for coronary artery disease. If you have it from your family, then we can't do much about it, right? Even though with that, you still can do some screening tests to prevent from getting acute coronary syndrome or coronary disease. But in the main theme is to just 80% of it is preventable. Remember, what is the pathophysiology? I think we all have completed step 1, but however, it doesn't matter. No matter how scholarly you get, you still have to know your pathophysiology. So basically what happens is, if there's a blood vessel that consists of 3 layers, right? let's say we have a blood vessel that has a 3-layer vessel. This is tunica intima, and then tunica media, and then tunica adventitia. So what happens, the lining in the tunica intima is the one that's responsible for the protection of the blood vessels. They are known as endothelial cells. So they get damaged. Once they get damaged, what happens is the subendothelial gets exposed. Basically the immune cells starts to migrate into here and starts to release chemicals and cytokines that leads to the proliferation of the smooth muscles and the formation of more endothelial cells, which are abnormal formation basically. And then what happens, the hypertrophy of smooth muscles and the deposition of the fats and lipids, the fatty cells or the foam cells, lead to the bulging or formation of a plaque that causes the narrowing of this blood vessel here, and the blood supply to the heart is decreased, and hence we have a myocardial infarction or decrease in blood supply to the heart, and leads to muscle cell death. So again, we're just going to say as the narrowing of the blood vessels due to endothelial damage, which could be because of smoking, LDL, and many other things, or inflammatory markers. Of course, if there's narrowing, it's going to lead to the anginal symptoms. It's because of decreased perfusion and increase in the oxygen demand, correct? And that makes sense to everybody, because if you have no perfusion, there's high oxygen demand to the heart cells, and then they will lead to chest pain, which is anginal symptoms. Of course, the anginal symptoms are most common cause of this is the narrowing, is atherosclerotic is the most common cause of anginal symptoms. But however, you can have chest pain not just because of the narrowing of the blood vessel, also due to aortic stenosis, because in aortic stenosis what happens, the valve is so stiff that it does not allow enough blood to go to the coronary arteries and still lead to decrease in perfusion. Pulmonary hypertension. What happens in pulmonary hypertension, of course, the blood cannot push to the left side, and we're left with decreased blood supply to the left side of the heart. Hypertrophic obstructive cardiomyopathy, similarly like aortic stenosis, the blood cannot push out, and the heart needs volume and volume overload. In volume overload, you know that by itself the lungs are filled with water, and you lead to lung problems and decrease in cardiac output and all that. Okay, so what about the sensory nerves? How do you feel that pain around your fingers and below the jaw and all that things? Then you might be like, okay, well, how does this happen? This is a little bit confusing, because I mean, how does your heart relate it to your fingers? Okay, so if you guys remember that there's some spinal cord tracts, the sensory nerves that are coming out of the heart comes from C7. It goes through the spinal cord tracts C7 and T4. So whenever you have some sort of pain in the heart or anything like that, these tracts carry the spine. These nerve fibers go through these specific spinal cord tracts, and it goes up to the cortex, and it causes you to feel the pain. So that's why C7 to T4 is the spinal tract that carries the sensory fibers from the heart. All right, so we're done with this, and now we're going to talk a little bit about the risk factors. What are some risk factors? This is important for you guys to understand, okay guys? So now we're talking about risk factors of coronary artery disease. There's modifiable and non-modifiable. Modified means that something that you can possibly fix. I know one, and that is called, let me just use another marker, and that is called smoking. Smoking is number one. Number two, hypercholesterolemia or hyperlipidemia. I can take care of that, correct, by using statins. Number three, how about, let's say you can even use hypertension. I can control hypertension. What about sedentary lifestyle? Is that correct? Yep, that's perfectly correct. So we can use sedentary lifestyle as one, and I can fix that. What are some non-modifiable? Family history, correct. Family history. And what about another one? You know, diabetes mellitus is a little bit confusing because it's non-modifiable. In a long term studies, it has shown that diabetes mellitus, regardless of how good you take care of the sugar level, there's a high chance that you will develop the coronary artery disease. So I will consider this as a non-modifiable as well. But as we can consider it in different, there's different opinions of of the scholars that are talking about how this can be affected and not affected. So let's say, okay, so that's one, and the number one modifiable or preventable cause of CAD is coronary artery disease is smoking. So if you stop smoking, you can prevent CAD, and that's the most common preventable. Prevention wise, here we go: smoking cessation, weight loss, controlling diabetes mellitus, good exercise, blood pressure control, and statins of 40 to 75-year-old use of statins, and higher percentage of risk patient, low dose aspirin, and so yes, and also you can use low dose aspirin with a 10-year risk of greater than 10%, and no basically no contraindication to the use of aspirin, for example GI bleeding or any sort of other bleeding and stuff like that. So these are some prevention methods. Of course, guys, it's very important for you to know the mostly preventive methods on how to prevent coronary artery disease, and exercise, smoking, weight loss. This is much more common sense, except for the statin use. When you know that the ACAS, atherosclerotic cardiovascular disease risk, is greater than 7.5 to 10%, then of course you're going to have to use a high dose statin or moderate dose statin for those patients that are 40 to 75 years old. Okay, and of course the use of aspirin with no risk factor. All right, some commonly associated conditions with CAD. You know, this is the commonly associated. For example, of course, if somebody has a CAD, you know, you have hyperlipidemia, you have peripheral artery disease. These are just associated. I don't mean to say that they are exactly, they have to be present if you have coronary artery disease. There's something called coronary artery disease equivalent. And honestly, if you remember, peripheral artery disease makes so much sense, right? Carotid disease makes another sense, because these are also same thing, narrowing or atherosclerosis of the peripheral arteries, carotid arteries, say, is that right? And diabetes mellitus, correct? So these are equivalents. Or aortic disease, for example, abdominal aortic disease, aortic dissection. These are all the equivalents of coronary artery disease. So if you have any of these, think about it, you might have this one too, or you have this, it is equal to, basically that's what it is. All right, what is Levine sign? Let's talk about, we talked about the associated. Now let's talk about what is the patient going to present with, the history, or how are they going to let you know. First of all, the patient of course is going to come to you either in an acute setting, in an emergency room, which we said we're going to talk about acute coronary syndrome in a bit, but we're just talking about normal coronary disease, which is the stable angina. So let's say if the patient presents to you and they say, oh, I have a feeling of chest pain. Levine sign is basically chest pain or heavy feeling, basically in the middle of the chest. It's like a pressure feeling, heavy pressure feeling in the middle, like a fist sign. They hold onto the middle of the chest, and that's kind of the Levine sign, basically. And the pain is very typical. How is the pain typical? It's not pleuritic, meaning that the pain does not go away with respiration. It is not positional. They do not move around and they have the pain. They have literally the pain present at the specific time. For example, it could be for 15 minutes, for 10 minutes. It's not go away with pressing. It's not reproducible, meaning that it does not, if you press the chest wall, it doesn't go. Not reproducible. It doesn't go away. As well as, what is it? Another thing is that the pain and the pain and the character of the pain is the same, and the location is the same. Dyspnea can happen on exertion, but possibilities is when they rest, their dyspnea might go away. So high chance that they might not have dyspnea. But these patients, when they present to your office, at that point they do not present with that symptoms. They had the symptoms possibly yesterday by telling you, hello doctor, I'm here to I wanted to just tell you that I had a severe chest pain and shortness of breath like yesterday when I was mowing my lawn, or I was just exercising, or something like that. So this is much more like this kind of cases we're talking about. On a physical examination, it's a little bit confusing. You know what, the physical exam is pretty much normal. For a normal physical exam does not exclude the possibility of coronary artery disease. But if you do a cardiac exam thoroughly, there's a high possibility that you might see if the patient who has coronary artery disease uh, could possibly have signs of CHF. If they, for example, have like myocardial infarction and stuff, they will present with signs of CHF. They might have heart murmurs, because of the valves that are deprived of the blood vessels, deprived of the blood, and have led to the formation of weakened walls and possibly murmur formation. Possible arrhythmias can happen due to the decreased blood supply to the heart, due to stress or anything like that. But you can have possibility of like evidence of peripheral artery disease, narrowing of the blood vessels of the periphery, and for that you have to check the peripheral arteries to see if there's any diminished pulses, any bruits or abnormal, or any abdominal aortic aneurysm. So all these could be signs of physical signs that you can basically look into and see if you notice anything. But at that time, some people just present to you with that complaint, and then you have to start thinking that what should I do with this patient. This is the hard part. As we said, we're going to talk about acute coronary syndrome next video. So this is where we're going to have a problem, ladies and gentlemen. Not a problem, but it's a little bit more complicated. Let's say I'm talking to you guys and I'm giving you a case of, for example, what is it called? I give you a case, and let's say this is the case. The case is that a 25-year-old patient presents to the office, presents with complaint of chest pain. Not 25, let's say I can get this to a 55-year-old lady. Presents with chest pain. 2 days ago. And on exertion or on exercise, okay. And she has no risk factors, or she has no risk factors, and pain was located in the middle of the chest, and radiating to jaw, as well as shortness of breath. She has a family history of coronary artery disease in father at age 50. Okay. All right, so that's about it, and now she wants you to basically test her. So what do? We look at, this is a 55-year-old patient, of course. Now I'm confused. I go ahead and I'm like, okay, this lady, she also has a past history of GERD, let's say. So now I'm confused. Okay, is this patient having coronary artery disease? Is she having pleuritis? Is she having, for example, GERD, exacerbation of GERD? Is she having a pneumonia? What's the problem right now? And with all these taking into action all these, basically you're kind of confused. So what do? You're kind of like lost, and you just want to make sure that this patient is also safe. You look at her in a category of like this way. So what we do is we kind of risk stratify her. Okay, what is she a low risk? What does it mean, a low risk? It means less than 40 years old, first of all, no risk factors, okay? And atypical chest pain, it means the chest pain that is shorter, that the patient has chest pain, it is good, but does not really represent an exact chest pain of a coronary artery disease. How is the chest pain of a coronary artery disease, by the way? As I told you guys, it's supposed to be persistent. It does not go away with respiration, no changes in positional. It is present, and the pain is the same, anginal episodes of same character and the same location. And no other changes, and no, it's not reproducible. So that's called typical, and the atypical is something that's not like that. Intermediate, like let's say this patient had a typical, for example, chest pain, and her age is greater than 50, so of course greater than 40, but we consider it 50. So let's say age is greater than 50, her intermediate, she's basically falls in the category of intermediate, even with no risk factors, but family history could be a risk factor for her at this point. So right now the high risk would be somebody who has greater than 60 years old or 65 years old, with many risk factors and stuff like that, and then possibly typical chest pain, let's say. At this point, make sure you just get this person to go to the emergency room and get a coronary angiography done. Do not further qualify this for ask her to go ahead and do a stress test, because this patient is high risk, possibly having even risk factors, and presents with a typical chest pain to your office, and you're not going to go ask her to go do stress testing at this point, because you can kill this lady, or it's a man, whoever it is. If intermediate patient, you know that this patient, for example, we say she can have typical or atypical, but let's say if she has atypical, she's greater than 50, and she has a family history, I'm not sure if this is GERD, if this is pneumonia, if this is pleuritis, whatever it is. I'm going to go ahead and do one thing. I'm going to go ask her to do an exercise tolerant test. Right? If she can exercise, I'll ask her to go ahead and do an exercise tolerant test. If she has a normal ECG, we will do the regular exercise recommended ECG. But if she has an abnormal abnormal ECG, then we'll have her do an exercise tolerance test with either echo or perfusion imaging. That's it. If she cannot exercise, then we can consider pharmacological therapy or pharmacological exercise testing. We basically give dobutamine or diprodamol to increase the heart rate, and then you can do an echo perfusion imaging with that. Okay, ladies and gentlemen, so this is how you have to determine if a patient is low risk, intermediate risk, or high risk. And this is the high yield part of this lecture, because if you understand this, any patient that comes to your office basically has an understanding. I mean, you can understand to send this patient for exercise tolerance test. Remember, ladies and gentlemen, there are some patients that might present to you with an exercise tolerance with like stress test that is negative, and however these patients have constant symptoms, continued symptoms. For these patients, you can do something called coronary CT, coronary angiography, or cardiac MRI, and you can detect, sometimes you can detect it with that one to see if there's any kind of narrowing of the arteries and coronary artery disease possible. So this is it. So you understood the low risk. That I keep reiterating this, guys, because it is the high yield part of this whole lecture. You have to be able to risk stratify your patient. If you cannot risk stratify your patient, you're going to send a patient who is younger to a stress test for no reason when having atypical chest pain, no risk factors, young, and he's possibly having some sort of costochondritis, and then you send him for stress test. You're going to be very upset at yourself. But however, you're going to be mad at yourself too if you cannot detect a patient who is in the intermediate category, because this is the one that we have the highest yield for us to be able to figure out if they have coronary artery disease or not. Because the patient who are at a higher risk are going to present to you with the symptoms that are typical for coronary artery disease. They will also be higher and like very old in age, and they will have typically risk factors like hypertension, cholesterol, diabetes, specific risk factors, right? But the intermediate ones are the ones that's your job to detect, and that's the office cases, and you will be noted in the exam. You will be asked many questions on if, and you will be very confused to see if this patient is coronary artery disease or not, has coronary artery disease or not. And the most important thing is, what are you going to do next for them? Of course, you're going to send them for stress test, and stress test consists of exercise tolerance test and pharmacological therapy. And exercise comes with normal ECG or abnormal ECG, and then from there on you can understand what you're going to do next. All right, so Now we're going to jump further a little bit just to make it simple. We're going to jump, let's say we got the stress test and it's positive, and now what are we going to do? We're going to go to angiography. Of course, we want to do angiography because we want to make sure that how much is the narrowing, percent narrowing. Of course, 70% or greater is known as stable angina, which is reversible upon rest. And if it's greater than 90%, they're unstable, so you have to get them to stent. Now, even sometimes greater than 90%, they might not have symptoms, but it's always, they usually prefer to have stenting done at a 90% or more to be safe and the safe side. Some general measures, of course, what you can do is to decrease the blood pressure of the person by giving them some ACE inhibitors or thiazide or calcium channel blockers. Keep them less than 140, except for the elderly patient that you want to keep it less than 150. Smoking cessation, of course, very, very important. Weight management, very important. Activity is another level that you have to be at. Exercise about 30 to 60 minutes, 4 to 5 times a week. Beta blockers. Okay, so metoprolol can be given 25 to 400 milligram daily. This decreases the heart rate, but make sure you keep the resting heart rate to 50 to 60. You can give another one, carvedilol, and if you don't want to give metoprolol, nitrates are very good medications. They decrease the preload, and it can be used as needed, for example, in chest pain. Statins are very good. Statins have been shown to be decrease mortality. Basically, aspirin can be used. Aspirin, as we said, can be used if there's no contraindications to aspirin, and if sometimes even with contraindications, aspirin has been used because the benefits outweigh the risks. After all these treatments, and if the person still feels symptomatic, then you can use ranolazine. It decreases the calcium in the cardiac myocytes and lead to anti-anginals. It's basically an anti-anginal effect on the symptoms. So this is about it, ladies and gentlemen. I don't want to take a lot of time. I understand that it is a very hard topic to talk about. There's a lot much more to talk about, but however, we're going to move on to further. The next video talk about acute coronary syndrome, and that is a much important topic. So make sure you understand this as a basic for understanding the acute coronary syndrome. I hope you guys understood, and I hope I have not missed any points that are very important for you guys. We'll just go ahead and quickly review this one more time so we're on the right path. We said that coronary disease is basically the narrowing of coronary arteries, especially the epicardial arteries. Stable angina is basically pain, the discomfort in the chest that can be precipitated by exercise or stress, and is due to the narrowing or decreased blood supply to the myocardial cells or the myocardium. Acute coronary syndrome consists of STMI, non-STMI, unstable. We're going to talk about that next. Another important point that you guys have to I reiterate again on this, silent MI. We can refer to this as silent MI that can happen from these patients, elderly, diabetics, and women. And all right, so epidemiology you understood. Pathophysiology is high yield for this exam. You have to understand the pathophysiology. The mechanism is the hypertrophy of the smooth muscle and the hyperplasia of endothelial cells that lead to the formation of a plaque and bulging into the intimal layer and narrowing of the blood vessels. That's all. And sensory nerves, you guys understood that the spinal cords C7 to T4 carries that. Risk factors, you understood that, and that's about it, ladies and gentlemen. I cannot talk anything else, and thank you very much for listening to the lecture, and we'll see you soon. Take care. Bye bye.